Let's make it run. Dr. Wilson, welcome back to the show.
Glad to be back, Dr. Jason. Glad to
My
be back.
man's season 2. We got a new stage, new studio, new
Awesome.
drinks, same incredible content. We're just about to have a blast.
Amen.
So I do want to start off, though. One of the most important things to us is that we're giving to charity and we're giving our toast to charity. To start off, though, I would like to ask you, what are you drinking tonight?
I, Dr. Jason, am drinking Dasani.
Man,
High
the
quality
Coca-Cola
H2O.
water.
Yeah, that's
Great
right.
choice.
That's
Great
right.
choice.
We got
I
support.
have Grinch Punch.
Grinch
Punch.
What's
Yeah, it's a
Grinch
holiday kickoff. The most important detail of Grinch Punch is a rum-based cocktail. And we had a COVID-friendly Christmas gathering, and this was the big hit. We had a tasting of all the drinks for the show this season. We get together, record the videos for it. And this one won, and it wasn't even close. The cool thing we're doing this season is all recipes and how we made the drinks will actually be put on social media. The first part is the actual making of the drink, and that went live about 5 minutes ago. Now, what you'll be able to see in about 20 minutes is you'll be able to see the actual recipe. So everybody who wants to try out a Grinch Punch is available there, and that helps bring the awareness to the other pages. Man, with your incredible Dasani water,
Yes.
I would love for you to talk about the charity that you have sponsored tonight.
Yes. Well, Dr. Jason, it's the same charity I sponsored last time, and the same charity that my business, my practice sponsors, is Nashville Rescue Mission. This charity is close to my heart. It's something that I've personally served at through my church, but they house people who need housing. They feed them, they clothe them, and then they also minister the word of God to them. So food for the belly and for the soul. And so it's a good charity that I like to give to.
I love it, man. Absolutely love it. Love bringing that awareness and appreciate you giving not only your time, but your also financial support and bringing that awareness tonight. Can't wait to share that snippet with the world and make sure that they understand the value that you all are bringing, but as well as Nashville Rescue Mission. Tonight, we are going to get right into the topic because I'm so excited about this one. This is one of the most popular topics in the world of healthcare today, which is this whole concept of regenerative medicine. I would love for you to just start out and give us an example and just define, what does regenerative medicine actually even mean?
Yeah, sure. So when I say regenerative medicine, I think of how how you administer some sort of substance, medication, however you want to think of it, in order to allow your body to heal itself, to regenerate new healthy growth of healthy tissue to a chronic damaged tissue.
I think that's a really great example because so often that's what we hear and that's what we think of as well. And when we hear regenerative medicine, we think, okay, one of the greatest aspects of the human body is the body has a way for most of its tissues to be able to heal, recover, and respond. When we talk about certain injuries or certain problems, things do get a little bit trickier. And one of those where there's been a lot of study around this idea of regenerative medicine is in the knee. And we think about knee osteoarthritis.
Right.
And I really have a million questions about this, especially coming from your expertise on the topic, because when we think of that, we say, okay, well, what really is the scenario? Because when we look at the science currently, best evidence comes down to the things we know for sure when it comes to knee osteoarthritis is that, number one, that your BMI, if it's high, not so good for knee osteoarthritis. Also, having a bad trauma or injury or damage to the actual joint itself, also not a good thing as far as osteoarthritis and predicting outcomes later in life or how you're actually going to feel with your knee. If you've had a horrible trauma, that's a risk factor for having more issues later on. Also, having that high body weight. In that reality, when we think regenerative medicine, are we talking more the idea of I actually want to see that structure itself change? Or are we thinking more the pain side of it, hoping that that makes change? And I ask that because I think that's where the divergent of the topic really goes, is that what are we actually doing? Because we know if there's a structural change, it's how far along this continuum is the patient already. If they're already, at a point where their BMI is 47 or 49, the really high BMI, not a whole lot of exercise in their life, and had an old joint trauma, and that individual has a lot of pain, I wonder about that, as well as how much of this are we thinking on the early front ends if they're, say, 35, haven't had a trauma, but we are seeing some changes in pain. Where really should we put our mind as far as expectations? And the reason I want to go down that path is there's so many popular, be it a podcast or articles get shared on Facebook, where you may think you could fly out of the country, get a regenerative procedure, and then your whole world goes back to when you're 18 again. And I
Right.
just don't know, who are we actually talking to?
Right.
What should be some appropriate expectations? And I would love for you to just start diving down that path, and let's see where it goes.
Yeah. Um, there is so much to talk about with this subject, but you bring up a very good question about is this just to help relieve pain, or do we see structural improvement? I would One of the things that got me really interested in regenerative therapy was about 4 or 5 years ago. I came across a study that looked at patients with moderate to severe arthritis. And I'm glad you brought up the knee, because that is the most common joint that is studied in the regenerative field. But there's certainly plenty of studies, for all the joints in the body. But in this particular study, they looked at three groups of people. And each group, like I said, had moderate to severe osteoarthritis. One group was of the hip joint, one group was of the knee joint, and another group was of the ankle. And what they did is they injected them with mesenchymal stem cells, and then they followed them for a period of 2.5 years. And what they found in this study is, in all three groups, at the end of 2.5 years, they all had significant improvements in pain. They all had significant improvement in function, which was defined as being able to walk farther distances. And then, in particular, with the knee, one of the things that was so exciting for me was they took MRIs of the knee before the injection, and then
Mm.
6 months after the injection. And what they found was, 6 months after the injection, not only did they have decreased swelling in their knee, but in addition to that, it showed additional growth of cartilage. Now, the reason that's so exciting is because up
Big deal.
until now, we haven't seen anything that actually grows cartilage. You hear of supplements over the counter like chondroitin sulfate and glucosamine, and kind of the thought behind that is, yeah, it's something you can try, but maybe that'll help a little bit, but we just haven't seen in the science that actually grows any cartilage or anything like that. And so this is the first thing that I've come across that shows that, hey, you can actually build back some of that cartilage. So for the patients with bone on bone arthritis, or very thin cartilage remaining, to have the potential to grow some of that cartilage, or that padding in between the knee, is just astounding. And so I started doing I started doing mesenchymal stem cell injections several years ago, and we've had tremendous success with it. It really has been awesome. Even better results than I thought we were going to get. And it's been very encouraging. I've had many patients who were told that they need to have knee surgery done. And in some places, or in some circumstances, they were told that they would need to have knee replacement. And I injected them just one time with a stem cell solution. And here 3-4 years later, they're still doing great. No pain. They were able to avoid surgery, and they're doing great. I would say in my practice, what I've seen, nothing is 100% in medicine, but I have seen about 80, I would say about 80 to 90% of patients get significant improvement after injecting a stem cell solution into the knee. And then of that 80 to 90%, I would say the vast majority get somewhere between 80 to 100% relief. Now, like anything else, and those results are astounding.
Yeah. Yeah.
I mean,
To say the
you
least.
think about. Now, with that being said, there is a small subset of that population who maybe only got 50% pain improvement, and then an even smaller subset that, unfortunately, for whatever reason, they did not show any improvement. So, this is not. This is not a guarantee, just like nothing in medicine is a guarantee, but we have seen tremendous success with it overall.
Man, that's great. Let's talk more about the ideal patient for this. So when you're
Yeah,
thinking patient selection, right? So if you've
yeah,
got 100 patients coming in, they're all asking for it.
yeah,
And let's say 5 to 7 of those are the ones that you're like, you know what? If I had to pick, all things equal, cost neutralized, situation perfect, which ones are the ones that you're saying, all right, this is the one that I would say go stem cell before, say, another option?
okay. So I usually think of the stem cell option, and we can talk about this more in the future, but um, as something you try, maybe after trying other conservative treatments first, such as over-the-counter NSAIDs, like ibuprofen, naproxen, Aleve, something like that. Physical therapy or chiropractic therapy, like with yourself. And maybe they've tried a steroid injection in their knee. So they've tried these things, and they're wanting to they're wanting to avoid surgery. They have severe pain in their knee. I would say moderate to severe pain. And so that's usually what we look for. I would say some contraindications. Maybe the patients who this might not be, may not work as well, would be someone who is, let's say, morbidly obese.
Mm.
So someone with an extremely high BMI. And the reason is, if you think about it, let's say we inject those stem cells into the knee and it grows new healthy cartilage. Well, because of all that weight, it's going to break down that cartilage, and it's just, it's just going to break it down. So it's going to kind of ruin the results. And then also, I would say if there's any deformity to the knee, some people have um, an increased Q angle, which means that their knee, instead of their leg being straight, they have they're either knock-kneed or bow-legged. You could say. Trying not to use the medical terms there,
Yeah, no,
but
it's hard,
if
isn't
you,
it? Yeah.
yeah. But if you think about that, it doesn't change the structural. It doesn't change. I'm not sure how to say that. It doesn't change the angle from which the top of their leg connects to the bottom of the leg. It doesn't change the angle of the knee. So those are some things that I think about. Yeah, probably not going to be a good patient. I would say in most cases do qualify, and most people with moderate to severe osteoarthritis of the knee or other joints can do fairly well with this procedure.
You brought up a good point when you talked about, okay, we're going to patient select, we're going to find the right person that this is for. And a lot of times it's going to be the person that, they have some opportunity to still be active. They're not in
Yeah.
such a poor health decision or life situation where that they're not going to get the best response out of it.
Right.
It highlights an article I was reading just this week about the risk patients on COVID-19, actually. And one of the things that it said is that actually 150 million people currently qualify for increased risk for COVID-19 outcomes. And mostly that's because of increased BMI. So that their body weight has put them into a category that they're increased risk. 150 million people is half of all adults in America.
Yeah.
And when we hear high BMI or high body weight as a number one risk factor for knee pain, us lowering that is a major opportunity. But that is hard for someone that is in the middle of feeling terrible. I think that's the hard part, that it is so easy for us to step back sometimes, look at the facts and say, okay, well, what's the best science say right now? Well, if number one is we got to bring down BMI, that's the most important thing as it's related to just the knee and arthritic related pain. Okay, great. But that person feels absolutely miserable.
Yeah.
That conversation can sometimes be really tough. I
Yes.
know you brought up that for, in our world, when we're doing the rehabilitation side, one of the most important things, it's a really difficult discussion. And actually, we had on last season, we talked to Dr. Sullivan about this actually. It was that the hardest part is to communicate. That first few weeks of the rehab side is probably going to be uncomfortable. And the reality is we have to get you to a point where you can get strong enough around it, because there's a direct cause to your knee pain and then there's an indirect cause to your knee pain. The
Yeah.
direct cause may be articularly between the knee, the joint itself may have a problem that is your direct cause of current knee misery.
Yeah.
However, there are a lot of indirect causes. And if we can address those indirect causes so the direct cause gets a chance to not feel so miserable,
Right.
some great things can happen. I
Right.
think what you brought up is an option to be able to help the actual direct cause in a way that actually there's not been that many. The most popular, of course, has always been a steroid shot into the knee. So an articular, so we're going inside the knee to give a steroid shot. Can you speak a little bit about why would you pick a steroid shot versus why would you pick stem cell? When's
Sure.
somebody going to get that opportunity to succeed? And then when's a time that a steroid shot that maybe you would predict is going to go really well, but actually for whatever reason, it didn't help them at all?
Yeah. Yeah. So I do want to mention real quick. So when I said morbidly obese, I'm talking about a very high BMI. If it's someone who's just overweight, yes, I do think that this can still help and they can be an appropriate candidate. Now, speaking about the steroid, some reasons you would normally start off with steroid first. Number one, your insurance covers it. Let's be real. So, there's a financial consideration here. So insurance covers it. The reason you do a steroid injection, steroid acts to decrease swelling and inflammation inside the joint. So usually when you have arthritis and you have pain, there's also swelling in the joint. So the steroid acts to decrease that swelling and help alleviate some of the pain. Steroid injection typically helps maybe 3 months on average. And then it wears off, and then you have to get the steroid shot again. And so some people get caught in this cycle of having to get a steroid injection, every 3 months. Some reasons why maybe getting a lot of steroid injections is not a good idea. Number one, if you're diabetic, so steroids can increase your blood sugar, and that could potentially cause a dangerous situation, especially if you're diabetic. Steroids can cause a flushing of the skin, so you get a red sort of rash. It feels kind of like a sunburn. Steroids can also decrease your bone density. So if you have osteoporosis or osteopenia, meaning your bones are a little bit brittle, it can make that worse in the long run. So there are pros and cons to doing steroid. Usually steroid injection is kind of the first line treatment that that most people would try
Yeah.
who have chronic knee pain.
And I think that's something that the thing that we have enjoyed the most, and for all those viewers right now, any questions you have, please ask them, because right now we have Dr. Wilson, who's an expert in regenerative medicine. Any questions you have, would love to be able to ask him right away. And we have the comment feed active. So any questions you have, this is a great opportunity. When we think from our side, from the rehab side, the expertise side, there are times where they will come in with enough swelling on the knee,
Yeah.
and it's a degenerative knee, it's an arthritic knee. And a lot of times the patient already knows that. They've known that.
Right.
But now all of a sudden it went from, I have arthritic knee, and it's been that way for years. And then all of a sudden now it's miserable out of nowhere. Yesterday it was fine. Today it's miserable. In that case, when we see them, what we commonly see is they have an inability to walk normally anymore, right?
Yep.
They want to go walk, but they can't. It hurts too much. It's swelling continuously. They get the pain at night where it's just driving them crazy. From our side, when you do a steroid shot, the thing that we see very commonly, if it's almost like if the order goes right, it can be an incredible outcome. And that ideal outcome typically is they get the steroid shot and they immediately get to rehab. And the reason I say that is the one thing that you said that I thought was incredible is that it opens up a time for about 3 months,
right,
where most people get pretty significant relief and the swelling's down. What's very interesting about that, if you look at the research on the rehab side, guess what it takes for us to make major changes in health? The biggest thing that you'll see is the number one side is that we'll get times where the first thing you would want is great change in exercise. So they can start to do more. They can start to have more fun getting back to the things they enjoy, walking, exercising, etc. And that's something that maybe they couldn't do before because the pain was so intense. So by them getting that 12-week time span where now they can tolerate exercise without pain, we can have a much better outcome than we could previously. I think a lot of people need to understand that the rehab side can be very helpful when it comes to getting back to the things that you love and the things that you enjoy, because by doing those, you're able to start getting more movement. You're able to get more pumping on that knee. You're able to do the things that you want to do again without the limitation of the pain putting you back down. So I think that's the biggest thing, is that if you get that steroid shot, you open up that window of time where now we can do rehabilitation, we can do exercise and get it to where maybe you don't need that second steroid shot, because now you're ready to run again. You're ready to get back to things you want to, because now it's better. So I see that tag team happen all the time, go very successfully, which is you get the steroid shot, you get the swelling down, you get the pain down. Now we can take that and do some amazing things to get you back to the goals that keep you active. And then that helps you keep your other health factors in line.
Right. Yeah. And I think you bring up a great point there, Dr. Jason. A lot of times we do the steroid injection, they feel better for several months. So they don't want to exercise because I feel great. So why do I want to go exercise? Right. No, it is very important when we do that you get with Dr. Jason or whoever your therapist is, and you rehab that knee, you strengthen the muscles around the joint to help the joint. And so, yes, I'm glad you bring that point up.
I just think that can't be overstated enough. And so often, I think you're exactly right. If it goes in that order where, oh my gosh, I'm miserable, my knee's swollen. Now I get the steroid shot. Oh my God, my pain's gone. Turns out I was just deficient in steroid shots. If that becomes the mindset, we're in trouble. But if they understand, I've got this opportunity now where I can fix all the indirect reasons that I was having that to begin with, or if I can get the strength right so that now I'm not overloading that area of decreased cartilage, like now I actually have a really good opportunity.
Yeah.
Dr. Wells, you talked about the stem cell injections for the knee and some of the outcomes. Are there any other regenerative options that seem plausible, or at least the idea sounds good, but maybe mixed results? What's your
Yeah.
take there?
Yeah. So let me back up just a little bit. In the field of regenerative medicine, when we're talking about the knee specifically, I think of three basic categories. So you have stem cell, and I can go into the details of, there's different ways to extract stem cells, and we can talk about that in a little bit. But there's also prolotherapy, which is simply a dextrose solution, which is a sugar water type solution that you can inject inside the knee. And then there's also something called platelet rich plasma, or PRP. Uh, these are the three basic categories of regenerative medicine. If we look at prolotherapy, which is the sugar water type solution,
Mm-hmm.
injecting inside the knee, it can be beneficial. Um, Typically, what I've seen, though, is it doesn't work nearly as well as stem cells do inside the joint. And a lot of times, patients need many injections of prolotherapy in the knee. It's not just one shot like the stem cell injection is. I've seen the most benefit from prolotherapy in my practice when it's not used inside of a joint per se, but it's used with some sort of chronic tendon or musculotendinous injury. For
Mm.
example, I have a patient I just injected last week with prolotherapy. We've done his quadriceps muscle, and we injected it 3 different times with prolotherapy, and now his knee pain is gone because
Mm.
he had vastus medialis tendonitis. So where that quadriceps muscle attached to his knee is where his pain was coming from. The pain was not coming from inside the knee joint itself, but it was coming from that musculotendinous junction. And so I've seen a lot of benefit for prolotherapy when we think of the muscles and tendons. When I think of platelet-rich plasma, the way that is done is basically you extract, you draw blood, and then you spin it down in a centrifuge machine, and then you take out the part of the blood that is rich in plasma, which has growth factors and so forth that are good for the healing process. And so what I've seen for that is very similar to what I've seen with prolotherapy. It takes many injections when you're talking about injecting inside a joint, and it doesn't work quite as well. But it does work well, just like prolotherapy, with musculotendinous injuries, whether that's tennis elbow or an Achilles tendon issue or whatever. Um, but but if we're talking about stem cells, there are multiple ways to extract stem cells. You can get stem cells from your own body, in which case they can you can there are 2 different ways you can get from your own body. One is where they take a needle and go through your belly button and draw out some fat, filter that fat down, filter the fat cells down, and get the stem cells from that and inject that. Or they can insert a needle into the iliac crest, which is part of your pelvis, and draw out your bone marrow. And so the bone marrow can be used as well. And both of these ways are beneficial. However, it's not my preferred method of injecting stem cells, because both of those can be painful and time consuming. And however many stem cells you withdraw, that's how many you have to use.
Gotcha.
So you have a variable cell count. When we look at donor stem cells, one way is through amniotic fluid. And this way can be beneficial, but you don't get a really high stem cell count from that fluid. There's also potential for debris to be in there for which you could potentially have a reaction to. Uh, the type that I use in my clinic is called Wharton's jelly, and it is found inside the umbilical cord of live, healthy birth babies. And so what they do is they take the jelly inside that umbilical cord and they send it off to a tissue bank. The tissue bank tests it, runs tests on it to make sure there's no disease, and then they store it cryogenically, so that they freeze it, and then we order it. So the great thing about it is we can order these cells. We know how many stem cells we're getting. The type I use actually, when I inject stem cells, I inject two different types of Wharton's jelly. One type of Wharton's jelly has a preservative solution in it. And the purpose of that is the preservative solution saves those stem cells from being damaged when it's frozen. But the problem is that preservative solution kind of kills off some of the other cells that are supportive and help the stem cells flourish. So one type has a preservative solution. The other type has no preservative solution. So what happens with that is you lose the stem cells in the freezing process, but all of those growth factors and cytokines and hyaluronic acid, which is another very beneficial product for the knee, those are all saved. And so when I inject in the knee, for example, I will use both types of Wharton's jelly in order to maximize the results. And like I said earlier in the show, we've seen some really good results with it.
No, I think that helps explain a lot of the things, and I think it helps stimulate some of the questions, in the comments as well. I think so. We think of, all right, now there's going to be a quicker return time to be able to get this procedure done, because we're not waiting the time period of if we have to do,
Right.
if we have to graft from a bone, or if we have to then extract fat tissue. So if we don't have to do that, if we can skip that, and then now we can do the procedure. Well, one of the questions was, if we're injecting that into the knee,
Yeah.
how long is it actually staying active in the knee, or is
Yeah.
it just triggering a process, or do we even know what's
That's
actually
a great
happening?
question. Great question. So what happens is when you inject the Wharton's jelly inside the knee, the first thing that happens is it repairs the T helper 1, T helper 2 imbalance. And basically what that means is it decreases inflammation. It helps restore the inflammatory imbalance that is in the knee. So that's the first thing it does in the first few weeks. After that, and let me also say this, usually we see maybe only 20 to 30% improvement in the knee in that first month, because it takes time for these stem cells to mitotically divide in order to regenerate new healthy growth of cartilage or of tissue. And so, it doesn't just magically automatically grow the tissue. So usually after the second and third month, that's when we start really noticing a whole lot of benefit. And then I tell patients, you will find out what the maximum benefit of this injection is after 4 months. So these cells
Gotcha.
stay in the knee for a long time.
That's wild.
And then, of course, however much relief you get after 4 months, that's how much relief we expect to stay. And what I've seen is most of these patients, the results are lasting many years from one injection. They're not needing multiple injections or anything like that. And so, that's another benefit over something like a steroid injection, where you have to get it every 3 months, and you got the side effects of the steroids and all of that to deal with.
Man. So I think that opportunity is definitely there. What are some other joints that have seen an increase in this opportunity for the regenerative procedures? Obviously, we've heard about, some of the different tendon pains being something that people have thought through, because in the end, most people want to avoid a surgery if possible, right?
Yeah.
And I think the hard part is we have culturally is that we have this culture that we've looked at healthcare as this reactionary thing. And I think that's the hard part, is that we wait for something bad to occur and then now we take action of, well, I need it changed now. So it becomes that Amazon Prime type response. I'm out of toilet paper, hit it on Prime real quick. That's the same way we treat our medicine. And it happens to be that in America, acute medicine and our emergency departments, that's where medicine really does flourish in America. I mean, we are really good at emergency medicine when you look at it from country to country, but our mindset as a culture of just individuals in America is not as proactive, health centered as you would think it would be. So it's almost this interesting predicament of we've had to become better and better at coming up with these ways to be reactionary to problems. And I think that's where it's such a challenge, that I love everything that you're talking about. I think the opportunities there are fantastic. That's what our whole profession is based on, is helping the body heal the best way it can, and to fix the indirect issues around the issue so it has the ability to recover. But sometimes we need some assistance, and where we would like medicine to go is to be there. But the reality is we're not all the way there yet with all the different things. And we know medicine is going to keep getting better in that realm. Yes. But it's still, the elephant in the room is, what would be even better if we never got to that point, right? So if we're talking to people that are in their 30s or in their 20s now, at that age, you still feel pretty immune to any problem, right? Yeah. But the reality is that's not the case. There's this decline that's coming, or these issues that seem to sneak up, and then all of a sudden we wait to be reactionary in that last minute. And that's not how we want that to be. But if you're talking about, you're there now, well, let's pass on that advice to our loved ones that are younger. But now I still need to get out of pain. So our options right now that Dr. Wilson's been able to go over is, sometimes it is right to be able to get that steroid shot to get the inflammation down, opens up that window of time. Get in for rehabilitation, fix all of those indirect issues, get strong again, get active, calm that knee down, and then hopefully you never need that second steroid shot. But if you've gotten down that path where you can't get out of that, but may not be an indicator that, let's stay away from a total knee replacement, or a partial knee replacement maybe isn't right for them, then, man, we have this awesome opportunity that stem cells really need to be on the table as a conversation piece about how can that actually help me, versus maybe 10 years ago or 20 years ago when we thought it was hypothetical. We're getting into a different place where there's some pretty great anecdotes that you've been able to share tonight that I think are pretty incredible. Can you take me through another area of the body that you've been as impressed with or similar to the knee? I loved what you talked about with the soft tissue and the prolotherapy, and there were opportunities that you've seen some success, like with some thigh pain. But what are some other areas that you've been really excited about as far as the regenerative procedures?
Yeah, so if we're talking about stem cell, remember, I like to use that for joints. The prolotherapy and the PRP, that's more the musculotendinous injuries is what I like to use that for. So other areas I've used stem cells and seen good results would be the hip. I've done quite a few hips. The shoulder, I've done quite a few shoulders as well, shoulder joints. I've seen good results in those. The best results are seen in the knees. I will say that. Yeah. I will say on average, like I said earlier, maybe 80-90% improvement in the knee. When we look at the shoulder or the hip, I'm really looking at more like 50 to 70% improvement. So in general, we usually don't see quite as good of improvement, but still significant improvement. And if it helps someone decrease the pain, if it helps regenerate some healthy tissue in their joint, and allows them to be more functional, then I consider that a win. And so sure. I really, I like that aspect of regenerative medicine. And I like the fact that, and you touched on it earlier, as a doctor, a lot of times, patients come in, we give them a pill, and all we're doing is masking the problem. We're not fixing anything. We're just kind of delaying it. And kind of like with the steroid too, we're not really fixing anything. We're just getting rid of some inflammation that we know is going to come right back. Versus with the stem cell, we actually have the potential to help fix the problem. Now, of course, it can't fix every problem, but it does have the potential to fix quite a few problems. I do want to say also, it's not just osteoarthritis of the knee. If we're talking about the knee, I've had a meniscal tear, a patient with a meniscal tear. Ortho wanted to do surgery on her. I injected her 3-4 years ago. Meniscus is doing great. Knee is doing great. No surgery. She's working out and doing well. Another question I get asked a lot is there a certain age? Is someone too old to inject? Honestly, I haven't seen someone who is too old who can benefit from this. I've injected patients in their 90s, and we've seen some improvement. So, lots of people can benefit from this. It may not be your first line therapy. Again, you have the other, more standard things in place, but it does offer a really nice option before considering, say, surgery. So.
Yeah. Do you think we'll get to a point, or does the mechanism make sense that there will be some case where there's a surgical procedures that's done, but then they will, right on the back end of that, go straight to stem cells? Do you think we'll get there?
You mean like during surgery or after surgery?
Yeah, or just right after?
There already are orthopedic doctors I know of who do that. I already know some orthopedic doctors after they do, say a knee arthroscopic surgery, they'll go ahead and put some stem cell in there at the same time. So they're already doing that.
Yeah, and that seems to make sense. I think it'll be interesting to see where this goes, because we're in this insurance dominated culture.
Right.
So it's they're always their favorite phrase is that it's experimental, right?
Exactly.
It doesn't, it's a moving marker of at what point enough evidence gets to the point to where it's no longer experimental. But because that's their favorite category, at some point, if we get to where there's an overwhelming enough evidence for it, and then now they're covering it, I think that could be very interesting. The hard part's going to be, just like we see with the rehab side of things, it takes so long to do these studies, and it gets so cost intense to be able to do them, to get to the point where you could track people over, say, a 20-year period post-operatively or just after the injection and see how that changes their healthcare related costs and their health factors. Because it's just one facet, it's going to be, a long road for that. However, that is one of the barriers for a lot of things in healthcare in America, is that financial barrier. But outside of that, have you seen any other either adverse events or things that, like you talked about with steroids, they may get flushing the skin, they may not be able to sleep as well for a day or two. They may have these other side effects that come with it sometimes, even though a lot of those are rare. Are there any with stem cells at this point? What are the adverse events that individuals are worried about or concerned about as that's related?
Well, I'm glad you bring that up. That's a good point. So as it depends on what type of stem cells you're using. Okay.
Gotcha.
If you are using the type that we use, the Wharton's jelly, this particular type does not have HLA antigens on those cells, which means, so let me break this down for you. So if I inject my blood, if I draw my blood out and I inject into you, and we're not a perfect match, your body's going to reject that because the HLA antigens on those blood, my blood cells are going to be recognized by your body, and they're going to reject it as a foreign substance. The great thing about these cells that we use with Wharton's jelly, it doesn't have those antigens on them. So there's nothing for a body to recognize as foreign and react to. Some types of stem cells that are injected can cause an inflammatory response. And I have seen that with other types like umbilical cord blood, which I used to use in the past. And an amniotic fluid. I talked about the debris. You can see kind of this inflammatory reaction. With the Wharton's jelly, I haven't seen any inflammatory reactions. Now, I would say it's the same risk as any injection as far as you can have, problems with bleeding or infection. That anytime you introduce a needle through the skin, that's always possible. But The risks are extremely minimal with this. The biggest downfall, and you talked about this, to the whole field of regenerative medicine, not just stem cell, is the financial piece about it.
Yeah.
Because as you said, it is considered experimental by the FDA. Now, there's been a ton of research, okay? A ton of research, especially within the past, say, 15 years or so. Tons of studies. But they've been doing studies with stem cells, since like the 60s. But the bulk of it has been the past, say, 15 years or so. With that being said, you hear about all of the pro athletes getting either PRP or stem cell injection or prolotherapy. Look, tons of people are having these done and are having success from them, and so that part of it is really exciting. On the financial side, unfortunately, because it's considered experimental, whether it's prolotherapy, PRP, stem cell injection, insurance doesn't no insurance covers these treatments, and so they can be quite expensive depending on how many joints you're injecting, how much we're having to use. That kind of determines what the cost basis is, but that's the downside. But if you look at it from a different perspective, how much does a surgery cost? How much does medications cost if I'm having to get them every month and I'm not fixing the problem? And this is just something I'm having to do. How much is your health worth to you? I think that's the question we really have to ask. And so that's really what it boils down to. Um,
Yeah, I think that's very similar to I remember when there was that conversation back in 08, 09 about healthcare and where it needs to go is this idea of a health savings account. Everybody is allocating money away every month or every year to make sure that they can then get to a point where they can use their financial dollars to make their decisions that are best for their family. And then hopefully that's going to go towards a preventative route or to be able to set up a situation where now we're up against this wall. There is a financial hit, but absolutely, if I've prepped for this appropriately, now all of a sudden I have that opportunity to avoid the downtime from a surgical procedure or to avoid all the other consequences that can come from some of these things. But I think that's the hardest part is that just, again, back to that cultural response of, ideally, we're doing everything we can to prevent these things on the front end anyway. But
right.
if we do get up against the wall, hopefully we've put back in a health savings account a way to be able to have the options open to us, because that's the most heartbreaking part of this is that there are certain individuals that are not going to have the same opportunities as others as it comes to healthcare because of some of these different regulations. So if you're in the situation, if at all, to be able to start saying, hey, maybe I'm healthy right now, maybe this is that stimulus that you need to remember. It is important, even though it may not seem like it today, but having a health savings account, being able to put money away in case something does happen that's unexpected health wise, that you can be okay. I think that would be my biggest take home here. And that, these are the options that regenerative medicine is there. And I think we're going to learn a whole lot more about regenerative medicine over the next decade. I
Yes.
think it's so great to already just hear the anecdotes, the success that you've been able to see in our Nashville community. And I really want to just be able to highlight, the thing that is encouraging here by us having this conversation is, over the years, I've seen a lot about regenerative medicine, and they've been buzz ads or, they're all over the place, right? I mean, there's a
Yes.
ton of clinics that push
Yes.
this information.
Yes.
I think the part that's so great about this conversation is that we've had the benefit of getting to know you over several years and to watch your management skills to just a different level of quality and compassion towards patients than any of these ads that I can't say that for those in these ads. A lot of times I see these ads and I see them as money grabs, or I look at it from like a negative lens and I can't necessarily see the positive or what the good outcome could be. But it's a
Yes.
whole lot different when I sit down over a drink with you and talk about this, because I remember the first time we heard about your clinic, because there was a time in Nashville where when you hear of interventional pain or you hear of pain management, that was a runaway, sprint away type situation.
That's right.
And just like every field has, their
Yeah.
whatever, but our field, all fields, right? There's that
Yes.
subsection. But when it
Yes.
came to pain management, I mean, everybody just kind of watched out in our community for so long. And then I had another healthcare provider say, no, you've got to meet this guy because we've seen, cases that they went in there on opioids and they came out months later and they were off of them.
Right.
And the first time I heard that, I go, I'm meeting this guy next week. And right away, we hit it off great because such like-minded patient approach. And the
Right.
thing that's been incredible is that as each year goes on, it's just more and more of great management seeing. It's been just a great opportunity to see more and more cases get off of these different medications. And by having some of these other options changes everything. So having a compassionate physician that's here to give everything that they can for you. And I just see he was one of the big highlights in Nashville of if we need to open up that window of time for someone to be able to get back to the things that they love. If it's spine care related, there's just no question that they're going to get a great outcome from the team in interventional
Right.
pain. So I just can't thank you enough for coming back on the show, for sharing your expertise tonight. And I just wanted to say cheers, my man.
Thank you very much, Dr. Jason. I appreciate that, and you do fantastic work for us as well. It's been truly a pleasure collaborating with you. We've had tremendous success with our patients going through your therapy program.